Thank you, sir. Thank you for this nice words. Well, I'll be talking on vitiligo and Indian perspective. Well, vitiligo is a common acquired chronic disorder of pigmentation characterized by white patches. Around 0.5 to 1% of the world's population is affected with vitiligo, and India is amongst the countries with highest prevalence rate, varying from 0.46 to 2.16% in Chandigarh. Well, in Chandigarh, we have the Postgraduate Institute of Medical Education and Research. It's an island of excellence, providing physical and intellectual milieu for young scientists working in multiple disciplines of medicine to advance the frontiers of knowledge, to render humane service to sick and suffering, and to train medical and paramedical manpower. I was fortunate to have worked with this institute for 26 years, from 1987 till 2013, last year when I retired, and the work which I am going to present in this session was carried out at this very institute. So this is the Postgraduate Institute of Medical Education and Research, Chandigarh. Vitiligo is a disorder of great cosmetic significance and a source of considerable psychological distress and social isolation, especially in dark races. It is associated with significant impairment in the quality of life. Patients suffer low self-esteem and depression. They have difficulties in finding a job or getting married. Pandit Nehru, the first Prime Minister of India, ranked vitiligo as one of the three major medical problems, the other two being leprosy and malaria. The word vitiligo is derived from the Latin vitium, which means a blemish. In Atharva Veda from India, it has been described as kilas or white disease, and in Charaka Samhita, it has been designated as Savitra. The etiopathogenesis of this disorder is not clear. Most cases of vitiligo, they occur sporadically, although about 15 to 20% patients may have a positive family history. Mostly, the familial exudation takes a non-Mendelian pattern, polygenic multifactorial inheritance. Certain HLA types are associated with an increased prevalence of vitiligo, while HLA-P4QO is associated with a decreased prevalence. Vitiligo could also be an autoimmune disorder. A number of clinical conditions alleged to be of autoimmune origin, like thyroid dysfunction, Addison's disease, and pernicious anemia have been shown to be associated with vitiligo. Autoantibodies have been found against certain surface antigens of melanocytes, and the titer of these antibodies correlates well with the extent of depigmentation and response to therapy. Anti-tyrosinase antibodies have also been detected. There are a number of other hypotheses, like the neurogenic hypothesis, the oxidative stress hypothesis, melanocyte self-destructive hypothesis. Cytomegalovirus infection have also been implicated in the pathogenesis of vitiligo, and according to certain people, basic fibroblast growth factor deficiency can be associated with vitiligo. The hypothesis which is gaining momentum as of now is the melanocytorrhea hypothesis. According to this, the melanocytes are probably weakly anchored in the skin, and a minor friction can cause their detachment and produce depigmentation, the Cogner phenomenon. We carried out a study to assess the role of apoptosis and melanocytorrhea. It was a comparative study of melanocyte addition in stable and unstable vitiligo. Perilesional skin melanocytes from patients with stable and unstable vitiligo were cultured, and there were studies for morphological changes, addition to collagen type 4 and caspase 3 expression. It was observed that melanocytes from unstable vitiligo, they showed significantly low addition to collagen type 4 compared with controls and melanocytes from patients with stable vitiligo. Caspase 3 and annexin 5 staining was significantly greater in melanocytes cultured from unstable vitiligo as compared with the controls. And this is shown in this bar diagram. Further, it was observed that melanocytes from unstable vitiligo lesions showed perinuclear halo and they had blunted dendrites, while melanocytes from stable vitiligo lesions and controls showed normal dendrites and there was no perinuclear halo. So these morphological and addition findings support the theory of melanocytorrhea as the primary defect underlying melanocyte loss in unstable vitiligo. Liver X receptor alpha has been implicated in proliferation, carcinogenesis, differentiation, and permeability barrier function of the skin. LXR alpha mRNA expression was significantly higher in perilesional skin as compared to unenrolled skin of non-segmental vitiligo patients. This leads to decreased cell adhesion molecules and proliferation, resulting in detachment of melanocytes from basement membrane. So there are probably too many hypotheses of vitiligo. These are not mutually exclusive. Combination of these mechanisms can contribute to the etiopathogenesis of vitiligo. So we have a genetic defect, there is a defective addition, friction, autoimmune mechanisms, transepidermal accumulation, chronic melanocytorrhea leading to vitiligo. How do we classify vitiligo? The vitiligo global issue consensus conference classification divides vitiligo mainly into two types: non-segmental vitiligo and segmental vitiligo. In non-segmental vitiligo, we have acrofacial, mucosal vitiligo, generalized, universal, and a mixed type of vitiligo. And in segmental vitiligo, the involvement can be of one segment of the body, or it could be bi or multi-segments can also be involved. Clinically, the disease starts as a focal patch, and thereafter it may either stabilize, leading to a localized disease, or it may spread explosively or more gradually into generalized vitiligo. The most common sites involved are the fingers, hands, face, and other trauma-prone areas of the body. There is no sex predilection. Peak incidence is found in 10 to 30 years of age. In 25% of the patients, the disease manifests by 10 to 12 years, and in 70 to 80% by 30 years. The incidence of vitiligo decreases with increasing age. Segmental vitiligo affects young patients before the age of 20 years. It has got a relatively rapid course of few months, and then the disease stabilizes. There is involvement of one side of the body. It responds poorly to medical or phototherapy, and high rates of repigmentation can be achieved with surgical techniques. Segmental vitiligo. Again, segmental vitiligo. On the contrary, non-segmental vitiligo is a slowly developing condition with a tendency to progress throughout the years. In a small percentage of these individuals, arrest of the condition may occur. So this is generalized vitiligo. Acrofacial vitiligo. We carried out a study to assess the effect of age at onset of disease characteristics in vitiligo. Of 1,416 patients, it was observed that 85.5% had an early onset of disease, whereas 205 patients had late onset vitiligo. Patients with disease onset after 30 years had a significantly higher association with precipitating factors such as trauma and stress, higher incidence of positive family history, and a higher association with leukotrichia, that is gray hair. Early onset non-segmental vitiligo was associated with a higher incidence of photosensitivity and pruritus compared to early onset segmental vitiligo. Late onset vitiligo is defined as vitiligo occurring after the age of 30 years. It is a separate subset that manifests in patients with a strong genetic background, and hands are the most common initial sites to be involved. The disease onset may be preceded by a precipitating factor in a significant proportion of patients. So this is a late onset vitiligo. Mucosal involvement in vitiligo. There are few studies in the literature suggested that mucosal involvement is associated with progression of the disease. Is it really so? We did a comprehensive review of 241 cases of mucosal vitiligo. We divided them into 3 groups. In group A, patients had pure mucosal involvement, and in this we had 70 patients. In group B1, the onset of vitiligo was in the mucosa, and then it spread to the skin. The number of patients in this group was 35. And then in group B2, the onset was in the skin, and then the lesions spread to all the other mucosal sites. And the number of patients in this group was 136. It was observed that patients in group A, that is pure mucosal vitiligo, mean age at onset was 31 years, and 55 had involvement of this. History of smoking was commoner in this group as compared to other groups. So smoking probably acts as a low-grade thermal trauma to the lips, thus precipitating vitiligo in genetically predisposed individuals. There was no difference in groups related to history of associated autoimmune diseases, family history, size of mucosal involvement, no relation between involvement of mucosae and the extent of skin involvement. So therefore, in our opinion, pure mucosal vitiligo is a distinct subset. Commoner phenomenon. It has been reported as occurring in 21 to 62% of the patients in vitiligo, and patients with commoner phenomenon have a significantly older age at onset, and presence of commoner phenomenon in a patient with segmented vitiligo may be an indicator of subsequent development of non-segmented vitiligo. In this study of 1,416 patients, we observed that 6.6% had commoner phenomenon. And again, as reported earlier, patients with commoner phenomenon have significantly older age at onset, and they had a shorter duration of illness. Recently, the Vitiligo European Task Force group has divided commoner phenomenon into 3 types. Type 1, for which the diagnosis of AP is based on history. Type 2A, for which depigmentation is present on areas of chronic friction. And type 2B, for which depigmentation is clearly induced by trauma. And type 3, which refers to experimentally induced commoner phenomena. Trauma to the dermis rather than superficial epidermis is required to induce commoner phenomena. We carried out this time a prospective study of 202 patients of vitiligo, and we observed that commoner phenomena was present in 64.4% of the patients, and type 2A was the commonest type present in 116 patients. Again, these patients had an older age at onset, and they had extensive involvement. Now, since the predilection sites for vitiligo are located at areas of friction like the knees and the elbows and pressure, we question the value of assessing type 2A commoner phenomena. So therefore, in our opinion, definition of type 2A commoner phenomena needs more clarification since it is different from other subtypes. Now, treatment. Multiple treatment options are available. A positive approach is recommended involving explaining the nature of the disease process, the likely prognosis, and the treatment options with their expected results to the patient. The choice of treatment also depends on the morphological subtype and extent of vitiligo. Treatments which are aimed at depigmentation by stopping the melanocyte destruction include corticosteroids, azathioprine, methotrexate, topical calcineurin inhibitors, and phototherapy. And there are treatments which achieve depigmentation by melanocyte proliferation and migration, and these include phototherapy and mostly the surgical replenishment of melanocytes. Corticosteroids. Corticosteroids can be used both topically and systematically. Topical corticosteroids are the first therapy for localized vitiligo. They are recommended for facial and small lesions and in children. Topical potent and ultra-potent steroids, though found to be most effective, their use should be limited to 2 to 4 months, otherwise they would result in topical side effects like striae, atrophy, and redness. Systemic corticosteroids are indicated in vitiligo when it is progressive and unstable. So this is the response to topical corticosteroids. We carried out a study to assess the low-dose oral meaningful dexamethasone therapy in progressive unstable vitiligo. A total of 444 patients were analyzed, and they were given 2.5 mg of dexamethasone daily for 2 consecutive days, and they had all progressive unstable vitiligo. It was observed that in 408, that is 91.8% of the patients, the arrest of the disease was achieved at a mean duration of 13.2 plus minus 3 weeks. And in addition, some repigmentation of the lesions was seen in all patients after a mean of 16.1 plus minus 5 weeks. 50 of 408, that is 12.25% patients, experienced 1 or 2 episodes of relapse in disease activity, and they were treated with reinstitution of OLC. The mean disease-free survival until the first relapse was 55.73. Adverse reactions such as weight gain, lethargy, and eczema eruption were observed in 41 patients. So therefore, low-dose oral meaningful therapy with dexamethasone is a good therapeutic option to arrest the activity of progressive unstable vitiligo. Its effectiveness in controlling disease activity is comparable to that of other schedules in which systemic corticosteroids are administered at a much higher dose and with less adverse effect. However, it is not suitable alone for repigmentation of vitiligo lesions. Minocycline has wide range of anti-inflammatory, immunomodulatory, and free radical scavenging actions. In these 32 patients with generally progressive vitiligo, they were given oral minocycline 100 mg once daily for 3 months, and in 29 patients, the progression of the disease was arrested. And then we carried out this randomized control study to evaluate the effectiveness of oral meaningful dexamethasone versus oral minocycline in patients with active vitiligo vulgaris, and we observed that both dexamethasone OMT and oral minocycline were found to be effective drugs to arrest the disease activity in vitiligo. Immunomodulators, we have tacrolimus and mycoprodamine. They enhance pigmentation by their role in melanocyte growth and migration during repigmentation. This was the first pilot study from India where we assessed the efficacy of topical tacrolimus for treatment of childhood vitiligo in Asians. We treated 25 children with vitiligo with topical 0.03% tacrolimus ointment, which was applied daily for 12 weeks, and in 19, that is 86.4% of the children, there was some repigmentation at 3 months, and 3 had no response. And of these 19, repigmentation was marked to complete in 11 patients. So this is before treatment and after treatment. Before treatment, after treatment. Phototherapy. Ultraviolet B can induce T regulatory suppressor cell activity, and the released interleukin 10 is important for the differentiation and activation of T regulatory cells, which may suppress autoimmune conditions. Phototherapy increases the number of residual melanocytes, most probably by enhancing the melanocyte growth factors such as basic fibroblast growth factor and endothelin 1. And these are the various ways by which phototherapy can be administered. Now, in this study, we found that narrowband UVB is an effective therapy for vitiligo. It was just the initial pilot study of 14 patients, and it was observed that narrowband UVB phototherapy is effective and safe in Indian patients with vitiligo. So these are narrowband UVB therapy treatment pictures before and after. What about its efficacy in children? So this study was only the second study in literature evaluating the role of narrowband UVB in children. 26 children with generalized vitiligo were recruited, and they were treated with starting dose of 280 mg per square centimeter, and this dose was gradually increased by 20% on subsequent visits. The treatment was carried out for 1 year, and they were marked to complete repigmentation in 75% of the children. So it was concluded that narrowband UVB therapy is an effective and well-tolerated modality for treatment of vitiligo in children. What about PUVA versus narrowband UVB? Monitoring of compliance is important since phototherapy is time-consuming, and requires continuous high motivation of the patient. Now, since no drugs are involved in narrowband UVB, it has an advantage over PUVA. PUVA stands for Ptoragen plus UVA. Therefore, it is suitable for women during their childbearing years and for children. In this comparative study of systemic PUVA and narrowband UVB in the treatment of vitiligo, we observed that repigmentation was better in the narrowband UVB group, though the difference was not statistically significant. The color match was better with narrowband UVB and side effects were minimal. So this is pre-treatment narrowband UVB and this is post-treatment. Again, pre-treatment and post-treatment at 3 months. In this study, efficacy and tolerability of combined treatment in narrowband UVB and topical tacrolimus versus narrowband UVB alone was carried out. It was a randomized intra-individual open comparative study. Patients were advised to apply tacrolimus 0.1% ointment once daily at night on the lesions on one half of the body, and next morning they were exposed to narrowband UVB. The additive effect of topical tacrolimus in combination with narrowband UVB could not be fully established as has been shown by some other workers. So therefore, in our opinion, adding topical tacrolimus and asking the patients to expose to narrowband UVB really doesn't make much difference. What about targeted phototherapy? Most targeted phototherapy devices, either laser or non-laser, they emit radiation in the UVB range, which is around 308 to 311 nanometers. It has an advantage of delivering a high dose of light to a localized area. The treatment has been claimed to be effective, quick, and needing fewer treatment sessions. However, the disadvantages are it is more expensive and one cannot treat extensive areas with targeted phototherapy. The surgical repigmentation. The aim of surgical induction of repigmentation is to replenish melanocytes in the depigmented area, which either have no reservoir or they fail to activate melanocytes in the outer root sheath with known treatment modalities. Now, before the patient is subjected to surgical therapy, it is very important that the lesions or the disease should be stable. If the disease is active, the patient requires medical therapy. If the lesions are stable and refractory, surgical therapy is the treatment of choice. Now, stability, the concept of stability in vitiligo is multifaceted and there is no consensus on defining the criteria for stability. There are clinical, ultrastructural, serological and biochemical parameters to distinguish between stable and active disease, but there is no correlation of these parameters with the course and prognosis of the disease. The Indian Association of Dermatologists and Neurologists Task Force defines stability as that the patient has no reporting of new lesions, there is no progression of existing lesions, and there is absence of Wagner phenomenon during the past 1 year. So for surgical treatment, the most common modality which we have been using is the autologous non-cultured epidermal cell suspension (NCECS). Now this technique, which was pioneered by Gautier and Bézil group in 1992 in France, has revolutionized the scenario of surgical therapy of vitiligo. It yields cosmetically acceptable results in a short period of time. The technique basically involves 3 steps: harvesting of the donor skin, preparation of melanocyte-rich basal cell layer suspension, and dermabrasion, followed by application of the cells over the recipient area. Now, we have had many studies on this surgical treatment of vitiligo. Now, in this study, in total 36 patients with 80 lesions over acral areas and joints were reviewed, and of 80 treated lesions, 51 had regained more than 75% repigmentation. So, look at the repigmentation achieved by NCES. On the hand. Now, can suspending the autologous melanocytes in the patient's own serum improve repigmentation and patient satisfaction? Yes, it does. It was observed at the end of 16 weeks there was significant difference in repigmentation, that is in those patients in whom the melanocytes were suspended in their own serum and then they were grafted. So suspending the melanocytes in the patient's own serum helps in 2 ways. It increases the viscosity of the suspension and provides melanocyte growth factor. So you can see the results pre-operative and post-operative. Now this technique also results in the hair which has lost their color, they also regain their color. So these are the pictures which show that even the hairs which have become white, they also regain pigmentation by non-cultured epidermal cell suspension technique. See this improvement of leukotrichia. Now there are various other ways of carrying out surgical techniques, and in this study we compared the efficacy of autologous non-cultured epidermal cell suspension and suction blister epidermal grafting, and it was found that NCES has an edge over suction blister epidermal grafting in terms of extent of repigmentation, patient satisfaction, and ELQI. So these are the results with non-cultured epidermal cell suspension before surgery and after surgery, and these are the results with suction blister epidermal grafting. Now recently non-cultured extracted hair follicle center outer root sheath cell has also been shown to be effective in surgical treatment of vitiligo. In this study we observed that both these techniques were compared and their efficacy was observed to be similar. Camouflaging. Camouflaging the skin lesions is a useful option in some patients, and the proper use of camouflage improves the quality of life. The camouflaging may be temporary or it may be permanent. And in some patients who have extensive vitiligo and some areas remain pigmented, it may be worthwhile to depigment these areas, and for that we have monobenzyl ether of hydroquinone available as Denozin. So to conclude, presence of vitiligo in India is high. It affects the life quality index. The exact etiology is not clear. Melanocytoracy hypothesis is important. Classification into segmental vitiligo and non-segmental vitiligo is satisfactory, both from prognosis and treatment point of view. Onset of vitiligo after 30 years is defined as late onset vitiligo. It is a separate subset with strong genetic background and presence of precipitating environmental factors. Mucosal vitiligo is a distinct subset. Common type 2A phenomenon needs redefining. Oral minipulse and minocycline are effective in progressive unstable vitiligo. Narrowband UVB phototherapy is effective in both children and adults. It has an edge over PUVA. Non-cultured epidermal cell suspension is the most common surgical technique used in treatment. Suspension in patient serum gives better results. It is better than suction blister epidermal grafting, and camouflaging and depigmentation are required in some situations. So steps ahead. We need to identify the defects in the melanocytes which make them susceptible to destruction. What is the role of keratinocytes and Langerhans cells in pathogenesis, and what is the role of stem cells in management of vitiligo. Thank you very much for your patient hearing.
Thank you, Professor Thakur, for very good presentation. I'd like to reiterate the point. Vitiligo, we want to give this message, and vitiligo should be given. What cannot be done by medical therapy will be done by surgical therapy, and equal advantage and serving and patient vitiligo before to start. Thank you. May I invite Dr. Thakur to take the award certificate.
Thank you, Dr. Khanna, and thank you, Dr. Sharma, for chairing this session. So now we have a coffee break for 15 minutes, and there is an announcement about the posters. Those who want to display their posters, everything is ready and in the poster display area. So you can do that.